Good morning, everyone. I'm Mike Quaranta, President of the Delaware State Chamber of Commerce. Thanks for joining in on our webinar this morning, weighing in on workplace wellness. We've got a great panel. We're grateful to the good folks at Novo Nordisk for sponsoring this event. And let's get to it. We've got a lot of great subject matter to cover. We've got a great panel of experts who will share a lot of very helpful information for employers. And without further ado, I want to turn this over for an introductory comment and then the introduction of our panelists to LeVar Johnson. He's the Regional Account Manager at Novo Nordisk. He's an alum of Duke University where he played some football. I didn't know that about you, LeVar, but welcome. Thanks for joining in. And let me turn this over and the introductions to you.
Absolutely. Thank you, Mike. And thank you all who are able to attend this morning. On behalf of Novo Nordisk, thanks for the opportunity to speak to you all in a very concerning matter within not only your workforce, but also our country and definitely the state of Delaware. And that is weighing in on workplace wellness and the impact of a healthy weight and the disease state of obesity. It's my honor and pleasure to introduce the panelists and the speakers that we have for today. I think you all are going to learn a great deal more around how obesity and healthy weight contributes and impacts the production, short and long term, of your business and overall your the patients that are served in the community and your employees in order to gain a better health. First, I'd like to introduce Ms. Stephanie Belinsky. She is a state epidemiologist for the state of Delaware. Also, Ms. Lydia Wang. She is a pharmacist and medical liaison from Novo Nordisk. Lastly is Mr. Aaron Davis, the founder and CEO of Switchbridge, a healthcare data activation platform. These people are going to provide a great deal of knowledge today. And again, on behalf of Novo Nordisk, a global leader in the treatment of diabetes and obesity, we thank you. And please feel free to ask any questions in the comments section, and we will definitely have plenty of time for Q&A at the end of the presentations. I'd like to pass it over now to Ms. Stephanie Belinsky.
Thank you, LeVar. There are several different methods for defining weight categories. Due to the ease of data collection methods, the state of Delaware uses the Body Mass Index, or BMI, to classify weight into 4 categories for adults. BMI is calculated by a person's weight in kilograms divided by a person's height in meters squared. For the purposes of this presentation, we will be focusing on 3 of these categories: healthy weight, overweight, and obese. A BMI between 18.5 and 24.9 is considered to be healthy, between 25 and 29 to be overweight, and 30 and above is obese. For youth, the Youth Risk Behavior Survey, or YRBS, uses specific percentiles that are sex and age specific from the 2000 CDC growth charts. Youth who are between the 85th and 95th percentile are considered to be overweight, and youth at or greater than the 95th percentile are considered to be obese. According to the Centers for Disease Control and Prevention, obesity is a serious chronic disease. Because of this, obesity needs to be recognized as both a chronic disease in its own right and also a risk factor for other chronic diseases. Among Delaware adults, 36.5% reported being obese and another 32.1% reported being overweight. That means 68.7% of Delaware adults reported being either obese or overweight in 2020. Among Delaware high school students, 15.1% reported being obese and another 16.6% reported being overweight. That means 31.7% of Delaware high school students reported being overweight or obese in 2017. 2017 is the most recent data Delaware has for high school youth. It is important to note that the prevalence for adults and high school youth cannot be added. So let's put this into hard numbers. Almost 251,000 Delaware adults reported being obese in 2020. In that same year, almost 221,000 reported being overweight. Combined, that means over 471,000 Delaware adults reported being overweight or obese in 2020. Among Delaware high school students, almost 22,000 reported being obese, and another almost 24,000 reported being overweight, for a combined 45,700 high school youth being either overweight or obese in 2017. Let's take a deeper dive into the obesity trends over the past 2 decades. Obesity prevalence among high school students rose from 10% in 1999 to 15.1% in 2017. That's a 51% increase. Obesity prevalence has risen quicker for Delaware adults. In 2000, 16.6% of Delaware adults reported being obese. In 2020, 36.5% of Delaware adults reported being obese. This is a 120% increase in the past 2 decades. It's important to note there was a methodology change in 2011, so all trend lines using the BRFS must be broken between 2010 and 2011. This slide illustrates how obesity prevalence increases with age until about 45 to 54, after which there is a slight decrease. This small decrease may be due to mortality associated with obesity-related conditions. Notably, the largest increase is seen between Delaware adults aged 18 to 24 and 25 and 34. On the next slide, there are noticeable differences observed by race and ethnicity. Among high school youth in 2017, both 18% of Black and Hispanic students reported being obese, compared to 12% among white students. However, in 2020, almost 50% of Black adults reported being obese, compared to 33% of white or Hispanic adults. While obesity is a chronic disease, it's also a major risk factor for many chronic diseases, including diabetes, cancer, and heart disease. Other notable conditions include osteoarthritis, gallbladder disease, asthma, and sleep apnea. Among Delaware adults living with diabetes, 86% report being overweight or obese. And among Delaware adults with hypertension, 80% report being overweight or obese. The national cost of obesity and other chronic conditions are staggering. It is estimated that diabetes and prediabetes cost the US $403 billion annually. Cardiovascular disease and stroke cost the US approximately $363 billion annually. Cancer costs the US $209 billion annually. Obesity costs the nation more annually than cancer at a whopping $261 billion annually. It's important to note that these costs were gathered from peer-reviewed articles and cannot be directly compared because of differences in methodology. For example, the prediabetes and diabetes estimate includes both indirect and direct costs, while the obesity estimate only includes direct costs. This means obesity cost estimates are likely an underestimate. I would like to leave you with a quote from the Colley et al., the authors of the Obesity Economic Evaluation. Many of the aggregate national costs of obesity, $260.6 billion, represent external costs, providing a rationale for interventions to prevent and reduce obesity. Now I'd like to turn it over to Lydia, a managed care medical liaison from Novo Nordisk and an ambulatory care clinical pharmacist.
Thank you so much, Stephanie, for that great overview of obesity, both nationally and in Delaware specifically. So I'll now turn to talking a little bit more about the science of obesity and how it impacts the workplace. So we know that the contributors to our weight are complex and multifactorial. On a high level, there are numerous internal and external factors that play into the balance of energy intake and energy expenditure that can lead to obesity, such as our environment, genetic variations, your individual biology, socioeconomic factors, and some medications as well that can affect weight and lead to obesity. Our bodies, and more specifically our brains, defend our natural weight set points. So losing weight is beyond a matter of willpower and the kind of old school way of thinking to move more and eat less. really due to the physiology associated with obesity. And the more we understand as a medical community about obesity, it really validates why agencies like the CDC, World Health Organization, FDA, and the American Medical Association have all classified obesity as a chronic disease and a disease we need to treat more holistically. Digging just a little bit deeper into the science of obesity, the brain also plays a key role in obesity as it controls eating behavior and appetite on 3 levels. There are different hormones in the brain that strike a balance between feelings of satiety and hunger. There's also a center in the brain that helps with the decision to eat. And finally, there's the component of eating for pleasure, as we can see on the right side of the slide, which is controlled by receptors we may have heard of, like dopamine, opioid, and cannabinoid, which we often hear in relation to things like drug addiction. However, these receptors in the brain can also play a role in food addiction that can lead to obesity as well. And beyond these many factors of obesity we've discussed, there are also powerful neurohormonal factors at play that effectively defend the body against weight loss, thereby often making obesity a lifelong problem where weight regain or relapse is the rule rather than the exception. We can liken the body's weight set point to a thermostat where if you set it to 72, the thermostat will try to keep the temperature at 72. The body is similar in that there's a weight set point that it tries to maintain your weight at. So if the weight goes below the set point, your body goes into survival mode to try to bring that weight back up through changes in your hormone levels and metabolism. This phenomenon is called metabolic adaptation, and it makes maintaining weight loss a challenge. An example from popular culture is that of the Biggest Loser competition on TV, where the average weight of contestants at the start of the competition was 328 pounds. By the end of the competition, they had lost 128 pounds on average. And then 6 years after the competition, when we looked at these contestants again, they had actually each regained on average 90 of those 128 pounds. So as we can see, weight loss and the maintenance of weight loss is really quite a challenge. It is so important to understand the science of obesity and manage obesity as a disease state because obesity is associated with a host of complications, as we can see on this slide. Mental health disorders, chronic pain and arthritis, cardiovascular diseases, diabetes, and even cancers are all obesity-associated complications that have high costs, impacts on productivity and presenteeism or absenteeism, morbidity, and mortality as well. Additionally, obesity is actually one of the high-risk groups for developing severe illness from COVID-19. And there is also a higher prevalence of these obesity-related comorbidities as BMI increases, as well as a decrease in life expectancy and quality of life as your BMI increases. The burden of this epidemic of obesity is continuing to increase, with $1.72 trillion in the US attributed to the annual cost of obesity. The direct costs of obesity amount to over $480 billion, while your indirect costs, like lost productivity, absenteeism, presenteeism, these amount to over $1,200 billion. So this really makes obesity one of the top 10 most expensive chronic diseases, like cardiovascular disease and diabetes. Employers often bear the brunt of these high healthcare costs associated with obesity and the lost productivity costs. The cost of workers' comp claims increase substantially with increasing BMI as well. So unfortunately, if these obesity rates continue to climb at the current rate, the future workforce is at significant risk to be an even greater health economic burden. If we look at obesity in the employer space in more detail, this figure actually does a great job depicting how increasing BMI affects direct and indirect healthcare costs across multiple industries in the US. So orienting you to this chart, we have mean direct and indirect healthcare costs per patient per year along that vertical axis. Along your horizontal axis, you have increasing BMI classes from 30 to 35, 35 to 40, and then greater than or equal to 40. We can see that expenditures rise exponentially with BMI through the spectrum of the obese BMI category. especially at BMI levels 35 and greater. The BMI value associated with minimum expenditures is roughly 25, which is that threshold between healthy weight and overweight. And especially among the highest BMIs of greater than 40, your government, education, and religious services represented by that light blue bar, your food and entertainment services represented by the orange bar, and the manufacturing and energy industry represented by that green bar claim the highest healthcare spend. Fortunately, there is something we can do to help remedy these significant health economic impacts of obesity. Weight loss has a positive impact on complications, and greater weight loss results in greater health benefits. As little as 5% weight loss can help reduce blood pressure and blood sugar. And as the percentage of weight loss increases, there are further benefits to health outcomes, such as your improvements in cholesterol, osteoarthritis, and cardiovascular disease. Weight loss can even result in the prevention of type 2 diabetes and can help induce type 2 diabetes remission as well. Additionally, weight loss is associated with improvements in health-related quality of life and reduced drug expenditures. So how can we achieve weight loss that we know results in such positive health economic outcomes? I think we are all familiar with wellness programs and lifestyle modifications that are implemented as a first-line weight management strategy. While these lifestyle modifications are certainly the foundation of all weight management interventions and are a necessary component, alone they typically actually only offer up to 3% weight loss on average. However, when you add pharmacotherapy, 0.4% on average can be achieved. And beyond lifestyle modifications and pharmacotherapy, bariatric surgery is certainly an option that offers up to over 32% weight loss on average. So lifestyle interventions alone don't result in direct, measurable improvements in clinical outcomes or healthcare expenditure. Pharmacotherapy can help bridge that gap between lifestyle modification and those more intensive surgical options. So while we have several treatment modalities available for obesity, and obesity is increasingly being recognized as a chronic disease state, it should be managed as such. The key components of a chronic care model for obesity include lifestyle interventions, pharmacotherapy or medications, devices, and weight loss surgery. Unfortunately, there are several barriers at play, including the stigma and bias associated with obesity, as well as the need for patients to seek professional support for weight management, ensuring providers have sufficient education on obesity management and reimbursement for the obesity care that they provide. Coverage for this obesity-related care, and then, of course, sound employer strategies for wellness programs with some systemic multidisciplinary support. So clearly there's much more work to be done in the space of obesity management, but giving patients access to these wellness programs, medications, bariatric surgeries are the first steps. So now I will actually turn the presentation over to Aaron Davis, the founder and CEO of SwitchBridge, to further discuss obesity and workplace wellness.
Well, thank you, Lydia and Stephanie. Those were both very incredible, informative discussions there. So good morning, everyone. So by now you might be convinced, as the AMA was in 2013, that obesity is a disease and that it contributes to the emergence and or severity of other conditions. And if that's the case, then the path is relatively straightforward, and you can start by advising your pharmacy benefit manager to add anti-obesity medications, or AOMs, to your formulary. But if you need to convince others within your organization to get on board, as I expect most of you will, then prepare to be met with some opposition. Obesity often draws ridicule, stigma, and shame, and the psychological impact from those makes curing obesity even more difficult. A 2013 study found that weight bias is widespread and results in obese individuals being subjected to unfair and harmful treatment in nearly all domains of life. And complicating matters even further, internalized weight bias among obese individuals contribute to psychological distress and poor weight loss outcomes. But as you've heard today, the science is on your side. And I'm here to tell you that your health plan data is almost certainly on your side as well. So given the science and your group specific data, most of your constituents will become convinced that obesity is a disease that we can no longer ignore. It must be addressed strategically and through the health plan. Now, if you encounter concerns about the cost of anti-obesity medications, then criteria can be put in place to manage utilizations. So, for example, as you can see here on this slide, prior authorization criteria can limit these medications to just those members with BMIs over a set level, with certain comorbidities, with evidence of dieting failure, and or who are engaged in a regimen of physical activity. And similar criteria and outcomes can be required for the prescription renewal. Well, now I'd like to walk you through some data that we collected and analyzed to examine the need for anti-obesity medication coverage for one of our municipal clients, where we've mapped all of their health plan data from 23 distinct data sources, including 5 different carriers, 2 pharmacy benefit managers, a wellness company, the client's payroll system, et cetera. So this client, as you can see, has just over 33,000 members, including dependents. And as you've heard, and you can see in the chart above, there are several comorbidities that are either caused by, in whole or in part, or exacerbated by obesity. And we've ranked these by the average cost per member per year and have shown the increase in average annual cost each condition represents. For this illustration, we've ignored the cumulative impact of comorbidities, which obviously could result in even higher costs, as we'll discuss a little bit later. As you can see, these obesity-related conditions drive significantly higher costs. And then by examining the cohort of members with these conditions, we also found that these conditions are highly correlated with high-cost claimants. While obesity may not have been the direct cause of the highest cost conditions, it was often deemed to be a strong contributor. Now, as Lydia mentioned, this is also what we saw with COVID infections, where obese and comorbid patients experienced worse outcomes and even increased mortality. So I want to step back a second and let's discuss the role of chronic disease in health plan costs. Well, if you've been managing a health plan for very long, you know that a small percentage of members account for a large percentage of your total spend. The 80-20 Pareto principle applies. In this case, 10% of the population typically results in 64% of your costs. But what's not as apparent is the fact that there is a migration every year from low cost to high cost claimants. Therefore, we need to ensure that members with chronic disease are getting the right care from the right provider in the right setting at the right time and at the right price. And we need to support their efforts towards being cured, as Lydia said, in order to avoid disease progression and the exacerbations that lead to high cost. So, when left unmanaged, obesity-related chronic disease can follow a devastating trend. As illustrated here, the annual health costs for this overweight individual, let's call her Abby, might only be a few $1,000s per year. But unchecked, her increasing weight can lead to a number of other chronic conditions and even cancer. So the goal with anti-obesity medications is to help reach an inflection point where Abby can realize weight loss and get on the path to health, wellness, and even cure of these chronic conditions. Well, if we go back to our client for a second, we also confirmed that many of the most expensive conditions in the entire population were related to obesity. And when we drilled down and looked at just the cohort of members with obesity-related conditions, we found that those members experienced extremely high average cost per related condition. Obesity-related conditions were exacerbating other diseases, resulting in worse clinical outcomes and higher costs. But with this data, our clinicians, we can go back up one slide. But with this data, our clinicians were able to do targeted outreach to those members, either through coordination with the carrier's disease management program and or through other direct means such as member education, patient advocacy, coaching, etc. And this brings up another really important point. When offering anti-obesity medications, you should also ensure that your members have access to an approved weight management program. So next slide, if you would. But let's think about it. How do employees and their family members find out about the programs and services that are available to them? Well, this is the typical way. It's a beautiful once-a-year benefits guide where these incredible programs are highlighted on page 37 or 40, or, well, you get the idea. So most health plan members, quite frankly, never read that far. So they don't realize these programs are available to them. Or if they did pay attention during open enrollment meetings, they simply forgot about them and don't remember them when they're finally ready to engage and make lifestyle changes. So an advanced strategy is to leverage your health plan data to provide specific members with targeted, timely, and actionable information regarding your coverages and the supportive programs, along with easy to follow links to learn more and get started on the path to improving their health and their wellness. Finally, since the keys to achieving improved health and reduced costs are early diagnosis, treatment compliance, program participation, ensure that your wellness plan encourages and rewards employees, spouses, and even dependent children for getting physical exams, closing chronic gaps in care, and participating in your approved health and wellness programs, all of which can be tracked through your health plan data. Anti-obesity medications are an important tool in addressing the health impact and cost of chronic disease by giving obese members a really motivating jumpstart on significant weight loss and reduction in their health risks. Now it's my pleasure to return the presentation to Mike.
Thank you, Aaron. That's great. Appreciate it. I'm going to ask Lydia and Stephanie to come back on camera. And I've got a series of questions that I'm going to pose to all three of you. So thank you very much. I was writing down an awful lot. There was a lot of great information there. So thanks to all of you. Let's level set real quick. And Stephanie, I'll come to you first, but Lydia and Aaron, you can jump in if you like too. Let's differentiate between type 1 diabetes and type 2 diabetes. And then also, I want to add to that because I think it was your slide, or maybe it was Lydia's slide. There's other things that people, if you're not a non-healthcare person like myself, you might, you jump to a conclusion because you see somebody and you think, oh, well, it's hereditary because, Mike is 6'2" because his father was tall, his mom was tall, he's big boned, he's this, he's that. But there are a lot of other factors that I think one of you pointed into that might, that are things in your brain that kind of lead you certain directions. So if you guys could address some of that. Stephanie, let's start with you.
Okay, so the state of Delaware data collections actually do not differentiate between type 1 and type 2. So the prevalence I'm talking about includes all types of diabetes except for gestational diabetes. However, it is estimated by the National Diabetes Information Clearinghouse that between 90 and 95% of people with diabetes actually have type 2. So type 1 used to be termed juvenile diabetes because historically it was diagnosed in children. In type 1, the pancreas produces little or no insulin, and those living with type 1, they have to take insulin. The primary risk factors for type 1 are family history and age. Type 2, that makes up the bulk of the diabetes cases, is when the body doesn't produce enough insulin or the cells respond poorly to the insulin that they're making. And the primary risk factors for type 2 include having prediabetes, being overweight, being older than 45, having an immediate family member with type 2 diabetes, being physically inactive, having had gestational diabetes, or being either Black, Hispanic, or Native American or Asian.
Lydia, there were other factors. So let's unpack the hereditary piece for just a second, if we can. Aside from my physical appearance, if I fit kind of a category, if you will, what other kinds of things might be hereditary that lead someone, or they just, this is the way they are. This is kind of what they got when they were born. What are some other factors that are beyond, if you will, the obvious physical features that we don't, that us lay people only kind of focus on?
Yeah, that's a great question, Mike. So I think there's a couple of things to mention here. Of course, is there's definitely a big link between obesity and especially type 2 diabetes development. Obesity itself has been shown to have anywhere from 20 to up to 80% link to genetics. So it varies from person to person, of course, but some people certainly have a higher disposition to develop obesity because of their genetics, because of their body's physiology. One of the interesting things we take a look at is twin studies. So when we look at twin studies with identical twins, they actually have a much higher percentage of body concordance, so similar body physiques. But then when you look at fraternal twins in these studies, they actually have a much higher figure of body discordance, so different body types. So that just really goes to show that genetics can certainly play a role in these body types, especially when you start looking too at these twins who are they grow up together or grow up in separate environments, because even those identical twins that grow up in separate environments, they still end up having very similar body types versus your fraternal twins that grow up in separate environments. They oftentimes have very different body types, but even in the same environment, they still have very different body types at the end of the day. So clearly genetics can play a big role, but there are, of course, there are times when this may not hold fast and true. So I think that's where you see a lot of that variation, that 20 to 80% genetic link to obesity, depending on the individual. The similar thing could be said about type 2 diabetes. We certainly know that there is some genetic link there as well, especially in relation to obesity being one of the big risk factors there. But folks are actually more likely, if they are twins, for example, to develop type 2 if one twin has it versus type 1. If one twin has type 1, the other one is not as likely to develop type 1 than a type 2, for example.
Interesting. Aaron, any comments on any of this?
Well, I think we have to be careful because there are also very unhealthy thin people as well. So we don't,
Right.
So we want to be sure that we're giving every person in the population the chance to have good health. And if it's obesity that someone's struggling with, then I think it's incumbent upon the health plan to provide them with the tools and resources and support to help them, become as healthy as they possibly can be. So.
Thanks. Stephanie, let's go back to you. We'll kind of keep going in this rotation. So as I was listening to all of you, and and Aaron, your point's well taken. You could be super thin and yet be diabetic or have other issues, for sure. I think a lot of times the general population doesn't think that. Stephanie, but obesity also has an impact on other kinds of health, and all of you talked about that. And I think, I'm 62 and I have friends that are getting knee replacements and hip replacements, and old hockey players like us, we all fall apart at some point. But I mean, what are some of the other issues that are maybe structural? And all of you kind of touched on this. There's the obvious issues, and then there's the kind of the other issues that are associated with this. But let's talk about some of the skeletal and those issues, because I think, boy, those are costly. Those are important surgeries.
Yeah, so obviously adding extra weight is going to cause problems on joints. Notably, I mentioned in my presentation osteoarthritis, which is different from rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disorder where osteoarthritis is wear and tear on the body. and often can lead to those more costly surgeries that can cause for long recovery, especially if someone is dealing with extra weight, because that can make the recovery more difficult from those surgeries.
Lydia, reactions to this?
Yes, certainly, connecting back to that, Stephanie is absolutely right in that it causes a lot, that extra weight causes a lot of wear and tear on the body over time. And similarly, too, not only are your procedure rates going up, but your medication costs can also certainly go up too, because a lot of the medications that we're using for these many different comorbidities associated with obesity are weight related or weight dosed. So as your weight goes up, you have to get higher doses of these meds, and that can lead to higher medication costs along with those higher medical costs as well.
Very good. Aaron?
Yeah, it's interesting. I was a broker for about 20 years before this, working with hundreds and hundreds of employer groups. And, we did a lot of work with wellness plans, and we had clinicians on staff that would help devise those. It was always interesting to me that most of the wellness plans that we encountered were designed to really, they focused a lot on fitness, right? And maybe on weight loss and so forth. But the problem that you often encounter is when you get down, like boots on the ground level, obese people have a lot of struggles even to move because of the musculoskeletal issues. Their joints hurt. It's hard for them. So putting in, for instance, a wellness plan that is all fitness and gym and everything else, I think we have to go back a step and meet people where they are. And one of the advantages of anti-obesity medications is that they're finally to the point where these kind of second generation anti-obesity medications there's really significant weight loss. I mean, we're seeing 15 to 20% weight loss with some of these medications, which gets a lot of that weight off of the joints, which helps people then become more active. So, I think, again, we just have to kind of meet people where they are and help and understand that it's not that people are necessarily lazy. It could be that they have some other health issues caused by the obesity that is causing them to not be able to participate in some of those kinds of programs that we know helps to reduce weight.
And that's a great point. If you're hurting, you're not going to run off to the gym and go do it, because boy, who wants to do that? So Aaron, let me start with you this time. Employers want healthy employees because a healthy employee is a happier employee. They certainly the employer then experiences fewer absences, could result in lower insurance costs. So how do employers approach this conversation with their workforce? I know that we have some people on who are HR professionals, and it was a delicate topic, right?
Well, it's a great question. And we could go in a lot of different directions. I'll just mention a couple of things here. First of all, is that we have to approach it from the perspective of compassion. We got to meet people where they are and understand that everybody has, a different story. They're coming from a different place. As an employer, oftentimes employees are skeptical. Well, why do you want to put this program in? Or why do you, what are you trying to get me to do? Well, if you approach it from the standpoint of really being there to help them achieve better health and so forth, that's critical. And one of the things that we did very successfully is we would have healthcare clinicians who would actually be available as either advocates or coaches to really share that level of compassion with them. And it's not just an employee issue. It's very often a spousal issue. It's even a dependent child issue. And the beauty of it is, if we can help mom and dad eat better, become more active, have a more movement oriented lifestyle and so forth, then we're going to help the children as well. Because these claims that come along, as I think it was, I don't know, it was Lydia or Stephanie mentioned it, but we used to call it juvenile diabetes. Well, they got rid of that term partially because children are getting type 2 diabetes at the age of 8 and 10 and 12. That had never been seen before. So
Lydia, what are your thoughts about this?
Yeah, I think employers need to definitely think about how weight management strategies aren't a one size fits all. So it's important to look at it from a lot of different angles, provide access to the variety of tools that are out there and available. So having access to things like the employer wellness programs that I alluded to, and the medications, and
Yep, you went on mute there for a second, Lydia. Somehow your microphone, there you go.
oh, I'm sorry about that. I think I accidentally hit the enter button that muted my
we
microphone.
lost you. Said you were at the point where you said want to make sure that employers make employees aware of wellness programs, and you were, pharmaceuticals and others. You were ticking off a list of things.
Yeah. So the wellness programs, the medications, the bariatric surgeries, because it might be surprising to hear, but less than 2% of those that would actually be eligible for medications, anti-obesity medications, actually receive them. And a lot of that is because they have employers or health plans that don't cover these medications. So it's important to make sure folks at least have access to the toolbox to make them successful, and ensure too that as we are looking at providing these employer wellness strategies, that we're looking at it from several different angles as well, not just medications, not just at your primary care, but also with your nutritionists and dietitians and your behavioral health interventionists, because all of these different professionals can certainly play a role.
All right, Stephanie, what are some of your reactions to what you've heard?
Well, I think Aaron and Lydia are spot on. Obviously, they have a lot of depth of knowledge around this. And the truth is, we are beginning to shift the way we think about obesity from just a risk factor to actually being a chronic disease in its own right. And with that shift also happens that we're not just looking at behavior change, which is very difficult, and telling people to go run on the treadmill or, eat fruits and vegetables is a great starting point for some people, but it's not the only place to get us where we need to be. And everyone has a different story, different challenges, different constraints on their life. And I think both Lydia and Aaron had said that, it's about meeting people where they are. I know Aaron said that. And that's what this is really about, making sure that the toolbox is full and that we are providing as many options and as many paths to success as possible.
Excellent, thank you. Aaron, I'm going to come back to you. Let's talk about wellness programs for a moment. My brother-in-law is a psychologist, and saw him last weekend, and he's frequently says a quote that goes something like this: takes on average months for a new behavior to become a habit. First got to change your behavior, and then it takes time, months later, for it to become a habit. So if that's roughly right, what are some of the strategies or combinations of things? We kind of touched on a little bit of this. Employers can do, employees can do, and employer wellness programs can support to make meaningful changes. I think we touched on this a little bit, but if there's anything else in wellness programs in particular that stand out to you, please offer your thoughts.
Wellness plans are a phenomenal tool. It's a great lever to have. So when you get into sort of choice architecture, right? So what are the decisions and choices we want employees and their families to make? The big problem with wellness plans is that, first of all, wellness plans have never returned a positive ROI in forever. Pepsi did a great study years ago where the ROI was about 50 cents on every dollar they spent. But then they looked at their disease management programs, condition management, and they started to see close to 4-to-1 ROI. So you want to use your wellness plan as a tool to really incentivize people to do the right things, right? So make people aware of the programs that you have available. So again, a lot of wellness plans were designed for healthy people, right? And I agree with that, quite honestly. I think it's great because a lot of employees show up every day and say, hey, look, I'm not sick. What do I get out of this health plan? Well, the wellness plan is there for them. But one of the things that needs to happen is you need to have what I would call a clinically efficacious wellness plan. And so the things that we're always looking for is get people diagnosed early, make sure they're compliant with their treatment plan, reduce health risks, and then ultimately work towards a cure. Well, you can build those kinds of features into your wellness plan. And one of the things that we've done, or just one example, is we would reward people for reducing their gaps in care. So here's someone who's got a condition, but let's say they're diabetic, haven't had their hemoglobin A1C checked in a year. Well, the data will tell us that, and we can reward them for closing that gap. So there are some more advanced, more clinically appropriate things that can be done in wellness plans. And then, again, also back to your point with what your, I think, brother-in-law was saying, is it's very similar to smoking. Smoking cessation, which was all the rage many years ago, was, we knew that it took several attempts before someone would quit smoking. Often, it could be 5 or 7. And I think we need to approach obesity with the same the same sort of understanding, which is it's not a one and done. It is a matter of people changing some lifestyle, changing their lifestyle and changing some behaviors over time.
Lydia, any other thoughts from you on this subject?
The other piece I would probably mention is looking at a variety of technology platforms to reach these patients, because the historical ways of having somebody come in for office visits every so often can be really challenging for someone's work schedule, personal schedule. So looking at platforms, digital platforms as well, your apps, using text messages, emails, phone calls, those things maybe in conjunction with one another can maybe form a more holistic program for folks that they can really engage in and stay engaged with, because we do know that a lot of times folks may engage in like the first really can fall off. So it's important to have these different methods.
If I could jump on that comment, Lydia, there is just an explosion of tools in the market, and I'm sure many of the listeners know there have been developments such as they're called SAMDs, software as a medical device as well, which really help people manage their conditions and even obesity. And as Lydia said, I couldn't agree more. It is, I think, incumbent upon employers, whether you're commercial, municipal, what have you, labor, is to make these tools available to people, because they are incredibly effective at helping people maintain their if they have a condition, to make sure that they're compliant with their treatment plans and so forth, but also to be doing all the things they need to do to reach cure.
Stephanie, before you chime in on this one, it's interesting. We have another session, another webinar that we're hosting on Tuesday, June 21st on wearables. And so, and I like where you were going, Aaron, and Lydia kind of teed it up. I'm old enough to remember, boy, you hit the big time when you got a beeper from your employer, and then, everyone got a phone. I wonder if, technology, if, I don't know what the HIPAA rules are around this, but if everyone was outfitted with a watch or something, all these different technologies now where real-time data is provided to you, so I'm more aware of my personal health, and then maybe to my provider, because I may not be feeling something, but they're seeing something. That if there's another strategy there too, as all this evolves. So wellness programs, technology, what are your thoughts?
So I personally have a Fitbit. I like wearable technology for myself, and that's not necessarily a position of the state of Delaware. Me personally, I obviously am a data person, and I believe the data can be very empowering. So it's a way, like you were saying, to get your own personal data right to you so you can see what you're doing. And one of the nice things about a lot of these different apps is that it can have food components, so calorie components on it, and it will actually take down how many calories you exercised off. So you know that if you ate that croissant, it's that many calories versus the egg in the morning, which is like maybe 90 calories or whatever it may be. And you can make those choices in real time with real data that will help to influence your behavior in a more positive way.
That's great. Lydia, I don't know if you want to mention and or say anything about maybe delivery of different things that help people with diabetes, maybe through wearables, or what's the connection there? So if, again, I'm a lay person in this group, but if I was obese and I had diabetes, what's some of the technology that helps me, manage my own care, and perhaps if things have been prescribed for me, what are some of the things that will help me achieve better results?
Certainly, yeah. I think it's so important in today's age to understand the need for real-time feedback, especially. So there's a big boom now with the wearable technology of continuous glucose monitors, where folks are able to see really shortly after eating what that food has done to their blood sugar. They can scan it with their iPhones or their smartphones, and they know what their blood sugar is. So from a diabetes standpoint, that's fantastic. They know exactly how their blood sugar is doing and how to manage that appropriately with what medications they're on. And for the provider too, that's great, because it'll actually interface and it can send a report to the provider's office for them to take a look at and see, oh, look at my patient, they're doing great on their current medications, or no, there's a red flag here, we need to be able to intervene earlier maybe than every 6 months that we see them in office. Maybe we need to call them up and say, let's make some changes, or what's going on. So I think that's of particular importance. But even from a weight standpoint, it can be helpful too, because then you understand, maybe when I eat, all of those little Debbie cakes, for example, not only does my blood sugar spike, but that can also make my weight go up too. So maybe from a holistic, health standpoint, that's not something I should be eating. Maybe I should be looking at, look at the positive benefits of exercise on my blood sugar and my weight. So certainly important to take a look at those things too.
Right. Aaron, I don't know if you want to, we've only got time for one or two more questions. I don't know, Aaron, if you want to say anything else on this, or I can just go on to the next question.
No, we could just go on. So we could talk about this for hours and hours.
Yeah, there you go. So one question that came in, are primary care providers equipped with the knowledge to assist with obesity as a chronic condition, or will patients be referred to a bariatric physician for care? Stephanie, let's start with you on that one.
So actually, that's probably better answered by Lydia and Aaron, because I don't deal with the clinical aspect of it.
All right, there you go. All right, Lydia, let's throw that one to you.
Yeah, I think I kind of alluded to this as well in that last slide I had up, but the education around obesity management for our providers is highly variable, and oftentimes it's very limited as well. However, there's always going to be primary care providers that maybe have more experience in managing obesity, that feel more comfortable in doing so, but then there are others too who would rather punt that off to your specialist, a bariatric surgeon or specialist there. So it's hard to say exactly, how much you can rely on a primary care provider, but there are a lot of efforts in the community right now, making sure that we can get this education and awareness out around weight management. So I think we'll start to see a lot of improvements in that arena, especially as we start to get more medications that can be used in this space. And we start to look at multidisciplinary care, getting our pharmacists, getting your nutritionists involved as well.
Very good. Aaron, any comments on that?
Yeah, actually, most obesity and even diabetes is treated by primary care doctors. I mean, obviously, endocrinologists, we think about those as treating diabetes, but actually, a lot of diabetics get their primary care from their primary care doctor. The other thing that's interesting, and not to move into diabetes, but about 95% of diabetes treatment is done by the member. That's why it's so challenging. It's watching what they eat and testing, and then deciding whether to take insulin or what have you. So there's a huge burden on the member. And oftentimes the primary care doctor, even the endocrinologist, doesn't know how well their patient is managing their condition. So one of the beauty, and I'll give a shameless plug for a company I just love, I'm not paid by them, but it's called WellDoc. WellDoc has a series of apps, and one is called Blue Star, which is a diabetes management app. And that will pull data in from continuous blood glucose monitors. It will track all that data. It'll send that data to the primary care doctor or the endocrinologist. It makes it available to medical management team as well in a fully integrated system. And those are the kinds of tools I think that you're kind of alluding to, Mike, that are really game changers for the future. And again, we have to present those as helping the member. It's available to the member. None of my clients, and we handle a lot of data for clients, none of my clients see the PHI, protected health information, for their members. And that's important because we're, HR, human resources, is now walking that fine line. I can't imagine that when most of the people on this call who got into human resources years ago thought, I'm going to be having discussions about what medication should be covered. I mean, these are really deep clinical issues that they're now getting, pulled into. But it's important that employees and their families know, as an employer, we don't see this data. We don't know if you're diabetic or if you're non-compliant or what you're taking or whatever. And that's really important from a trust standpoint, and to make all of these programs opt-in. So educate the member and then the employee, and then get them to choose whether to participate or not.
All right, we got one last question here. So then I want to go to each of you for a closing comment. So real quick, in the chat here, regarding childhood obesity and the prevention of adult obesity, and with the prevalence of the body positivity movement, as a parent, I find it difficult to successfully voice concerns on my child's eating habits because these comments are not well received. Boy, I've lived that one myself with my kids, and are quickly countered with body positivity objections. Any comments on how this movement could end up sabotaging healthy outcomes? That's a great question. Congratulations to the person that asked that. I wish I would have come up with that one. But that's a tough subject. Lydia, we'll throw that to you first.
Yeah, I know. I think it's important to note that there's probably a big difference here between body positivity and healthy lifestyle. And while certainly BMI is the most commonly used measure to assess obesity, it's not without its flaws too. We certainly see folks out there who have quote unquote overweight or obese BMIs who certainly live very healthy lifestyles and have no comorbidities and will go on to be very healthy individuals as well. So it's not so much about the body image or body itself, but more so just trying to encourage healthy habits, trying to encourage a good diet, lifestyle at the end of the day. And whether or not that has an effect on a certain person's body composition or physiology, that's beyond the point of the discussion, I would say.
Right. We've only got another moment or two. Stephanie or Aaron, anything on this topic you want to share?
Well, I absolutely fully agree with Lydia. I think there's two separate issues going on. You can instill healthy habits with your children by feeding them healthy foods, making it a daily practice of serving the fresh fruits and vegetables, and just kind of increasing that into what is normally seen, and also increasing physical activity and those kind of things without any conversation about how someone looks. And so the pivot away from how someone looks and into, but I want us all to be healthy, I want us all to live a healthy lifestyle and for many, many years, is important. And hopefully, you'll continue to have a healthy body, a healthy lifestyle. It's just being healthy in general.
Kind of lead by example.
Yes.
Yeah. Aaron, anything? If not, we want to close up.
I think you have to go back and address the body positivity with the kind of health positivity aspect that Lydia was talking about, and really talk to children about, well, what do you want to be able to do? because obesity is limiting. It, as we have heard today, and as you know, I think I'm convinced, I think many of us are convinced, it leads to a lot of conditions. And I think we need to talk to children about, well, okay, what does this mean if you develop hypertension, if you develop diabetes, if you develop cancers? And so, you know, one of the hardest things for people to do is to envision ourselves in the future, right? It's incredibly hard to do. But I think we have to walk through that process and say, okay, there is body positivity, but there's also this this idea of what kind of life do you want to be living? I mean, what activities do you want to enjoy with your children? You know, with your grandchildren even. And as best we can, we've got to move to that level, have that discussion.
Yeah, thank you. Well, this is great. I'm going to give each of you maybe 15, 20 seconds here at the end to say any final comments. But before I do that, I want to just flag for the people watching today. We've got some upcoming events, and I want to mention them just briefly. We have our end of session policy conference, which is Tuesday, June 7th. We have our networking breakfast at the Boy Scouts Ackridge Scout Reservation on Wednesday, June 15th. And we have a webinar, which I referenced earlier, on your health an arm's length away. We'll discuss wearable technology. And Intern Delaware kicks off a terrific program where interns from a variety of different companies and organizations all come together. And while you're selling them on your company, we're selling them on the experience of living here in Delaware. And so that if you tender them an offer, we hope that they stay here. We're in a fight for talent. We want to try to keep as many bright, talented people here in the first state as we possibly can. So with that, Stephanie, any final thoughts or comments on today's session?
So obesity is a serious chronic condition affecting over a third of Delaware's adult population, and the estimated costs of obesity are staggering and a major economic concern. Beyond obesity being a chronic disease, it's also a risk factor for many serious and costly chronic diseases such as cancer, diabetes, and heart disease. And I'll leave you with the words of Kali et al. Again, because I just think they were so good. There is a strong rationale for interventions to prevent and reduce obesity.
Very good. Lydia?
Yeah, I'll leave everybody with just the thought that obesity is a growing epidemic in the United States that we need to work on improved awareness and education of, and improved access to these different treatment modalities that are available for such a impactful health economic chronic disease.
All right, and Aaron?
Well, you know, I would just summarize it as, you know, from the employer standpoint, you know, health insurance is expensive, and it's expensive because healthcare is expensive, and people are demanding more healthcare than ever before. And so, as much as employers may not want to be in this position, I don't think you can rely on your carrier to provide all of the solutions you need. I think you need to become creative, innovative, own your data. Work with some consultants who have a clinical approach as well that can really understand what's driving your costs, and then what can be done to improve the performance of your health plan in years to come. And health plans are improved by healthier people.
Very good. Well, I want to thank everybody. LeVar, thank you, and Novo Nordisk for sponsoring this session. We appreciate all the panelists joining us today. We ran a little bit over time today, but grateful to everybody's participation. And thank you all, and have a wonderful afternoon.